I will give you a countdown. Then you
Okay,
can.
okay. ठीक है.
Okay, sir. So we are going live in 3, 2, 1. Please start, sir. We are live.
Hello?
Yes, sir. You can start, sir.
Okay. Good evening, everyone. As we all know that carcinoma lung is a very common malignancy in India and all over the world, and it has a very high mortality rate. Treatment paradigm of carcinoma lung has changed a lot in the last decade. Previously, we used to define carcinoma lung into small cell and non-small cell histology. And then with the event of IHC, the differentiation between squamous cell and adenocarcinoma came. Then we came to know about the driver mutation in carcinoma lung, specifically in the adenocarcinoma. And then various TKIs came into the picture. And now with all these newer molecules, the prognosis and the survival in carcinoma lung has improved a lot. Keeping these things in mind, as we know that it is very, very important for the all oncologists to know whatever the latest is happening in the area of carcinoma lung. So in this online webinar, so we have some various esteemed medical oncologists across Delhi NCR with us. So we have Dr. Manish Sharma, we have Dr. Aparna ma'am, and we have Dr. Ishu Gupta who will be joining us shortly. So this webinar has been organized in some part. So first, I will be inviting Dr. Manish Sharma, who will be talking about decoding treatment option in EGFR mutated NSCLC. Then we will have Dr. Ishu Gupta talking on overview of lung cancer. And we will have Dr. Aparna Dhar speaking on molecular biomarker testing in lung cancer. And then I will have a talk on osimertinib early EGFR mutated NSCLC patient, focusing on ADAURA trial. So we hope to gather good information in this webinar and learn from each other. So with this background in mind, so now I like to invite Dr. Manish Sharma, who is a consultant and unit head medical oncology in Action Cancer Hospital, Delhi. Sir, I will be inviting you to talk about decoding treatment option for EGFR mutated NSCLC. Over to you, sir.
Thank you, Dr. Kapil. Thanks for inviting me here. And yes, can I share my screen?
Yes, sir, please start, sir.
Is my screen visible?
Yes, sir.
Yes,
that is the problem.
Yes,
okay,
sir.
Okay, thank you so much, Dr. Kapil, for inviting me here. And in this evening webinar, we will be discussing on
confirm if my screen is visible so that we can start today's meeting.
The topic given to me is the decoding treatment option for EGFR mutated NSCLC, and I will be speaking on the different kind of drugs that are available for treatment of EGFR mutant NSCLC. What is the comparison between that? What is the survival benefit? What are the side effects? And then we will be speaking on the two real life studies on EGFR mutant NSCLC in the form of flower trial and OCFECT study. So we know all over the world, the lung cancer is the most common cause of cancer-related death. It accounts to approximately 18%, and it is the second most common cancer in the world if we include both males and females. But in males, it is the most common cancer, and the lung cancer is the most common cause of the death, especially in the late stages. So in both the sexes combined, lung cancer is the second most commonly diagnosed cancer, and it is leading cause of the death. So this is how we will be seeing the parameter which determine the choices of first-line therapy are progression-free survival and obviously the OS, which is very, very important. Then sometimes we need earlier responses. So overall response rates are very important. Presence of brain metastasis. Lung cancer frequently goes to the brain, and hence the drug which penetrates the blood-brain barrier is of utmost important. Then we need safe and less toxic drug for our patient, which maintains the quality of life. and the patient receiving subsequent therapy upon progression. So these are all 7 points on which the first line treatment of the advanced NSCLC should depend. And this is the slide talking about the various first generation, second generation, and third generation oral TKI with their PFS advantages. Gefitinib in the IPASS trial showed PFS of 9.5 months. Similarly, the erlotinib in the optimal trial, 13.1 months. Then afatinib in the Lux-Lung 7 trial showed PFS of 11 months, dacomitinib 14.7 months. And the most importantly, in the FLORA trial, the highest PFS was recorded in the form of osimertinib, which was 18.9 months in EGFR mutant NSCLC. And this is the depiction of the same, the progression-free survival, the various curves. The important thing here is to remember in the FLORA trial, the curves separated immediately just after starting the treatment, while they started to separate at around 12 months in the Lux-Lung trial, in the afatinib arm, and they started to separate at around 6 months while the patients they were on dacomitinib in the Archer 1050. Important here is to note that the Archer excluded all the brain metastasis, while the FLORA included stable brain metastasis, and it included around 19% of the patient who had brain metastasis. Similarly, the afatinib also in the Lux-Lung trial was given to the patients who had stable brain metastasis. So early separation of the curve that we see with osimertinib is very, very important. Coming on to the overall responses, overall response rate is one of the another parameter as we discussed. So in the FLORA trial with osimertinib, you find that the overall responses are to the tune of 80%, while for the EGFR comparator TKI, it was 76%. Similarly, overall response rates with afatinib, which we get is around 70%, gefitinib 56% in the Lux-Lung 7 trial. Similarly, around 75%, 72% in Archer 1050. And hence we can infer that the osimertinib has the highest number of overall response rates. Similarly, if we see the duration of response, it is also highest in the median duration of response is also highest in the osimertinib arm in the FLORA trial. If you see the median duration of response in Archer 1050 with dacomitinib, it was 14.8 months, while with osimertinib, the median duration of response is to the tune of 17.2 months in FLORA trial. So it has shown highest overall response rates and median duration of response. The curves, they separated immediately and they continued to separate. And the median OS is more than 3 years now. Osimertinib patients were more likely to be alive at second and third year, as we can see from this graph. And the first time an EGFR TKI has translated PFS into the significant OS. So we don't find OS with other TKIs as such, but it is only osimertinib which has given the median OS of 38.6 months as compared to the comparator TKI, that is gefitinib, in the form of 31.8 months. Lux-Lung 7 and Archer 1050, if we keep them side by side, afatinib failed to improve overall survival versus gefitinib in Lux-Lung 7 trial. Similarly, in the Archer 1050, the overall response rates, they were not statistically significant, and hence the formal statistical hypothesis for OS was not conducted, because the hierarchical gatekeeper procedure was planned for the hypothesis testing. That is, if PFS is more than the overall response rate, will be given significance, and if overall response rate are more than the overall survival, would be given significance. And hence the formal OS was not conducted in Archer 1050. It also excluded the patient with brain metastasis, although it reported a number of improvement of overall survival of 34.1 month for dacomitinib compared with 26.8 months for gefitinib. The trial had hierarchical stratified design, as we discussed, and hence the p-value cannot be assigned to the overall survival. So 28% of the patients were still receiving osimertinib at 3 years, while in the which is 3 times more than the comparator arm, that is gefitinib, in the form of 9%. Only 9% of the patients are receiving gefitinib at 3 years, while 28% patients receiving the osimertinib at 3 years. This trial also demonstrated that the patient with known CNS metastasis also have a good amount of progression-free survival. So with known or treated CNS metastasis, the osimertinib showed a median PFS of 15.2 months versus standard of care, which is 9.6 months, and the hazard ratio was statistically significant, 0.47. And those without known or treated brain metastasis, the CNS metastasis, the osimertinib had median PFS of 19.1 months, and the standard of care had the median PFS of 10.9 months. So this is the full analysis set for CNS full set analysis. The median PFS 16.5, sorry, median PFS in the osimertinib arm not reached versus for standard of care arm 13.9 months. Median follow-up is 12.4 months for osimertinib and 7.4 months for standard of care arm. So CNS PFS was also statistically significant with the osimertinib versus comparator. So this trial included almost 16% of the patients who had CNS metastasis, so around and was around 60. Number of the patients were around 60. This table summarizes the different kind of oral TKI which are available to us for the treatment, that is afatinib, dacomitinib, and osimertinib, the responses, response rates, and median CNS progression-free survival. So the afatinib in Lux-Lung 7 trial compared the afatinib with the gefitinib, and the baseline asymptomatic brain metastasis they were present in this clinical trial, and the median CNS PFS was 8.2 months versus 5.4 months in Lux-Lung 3 and 6, and it was 7.2 months versus 7.4 months in the Lux-Lung 7. So in Lux-Lung 7, you can see that the p-value was not statistically significant for CNS progression-free survival, while it was significant in Lux-Lung 3 or 4. So the afatinib has got some penetration into the brain, but the Archer trial, the dacomitinib did not include any patient with CNS metastasis, and hence CNS PFS cannot be assigned to the dacomitinib in Archer 1050, while the osimertinib had the highest CNS PFS of 15.2 months versus 9.6 months versus for the standard of care arm. And hence the patient with the data on the brain metastasis, they are not gathered in the erlotinib or gefitinib global clinical trial program. So the best CNS penetration is with osimertinib. Coming on to the safety, which is also very important for selecting our patients for the treatment. Grade 3 or 4 adverse events with dacomitinib were reported to be around 63%. So grade 3 or 4 even 63% in Archer 1050, while 31% for Lux-Lung 7 trial, and grade 3 or 4 events with osimertinib was reported just in 18% of the patient in the Flora trial. So the least number of the grade 3 or 4 adverse events they were found in the Flora trial in the osimertinib arm. And these are grade 3 and 4 second and third generation EGFR TKI toxicity. You can see that the various toxicity are skin problems, paronychia, diarrhea, and stomatitis, which is least with osimertinib and maximum with the dacomitinib. That is 14% skin problems with dacomitinib, 8% had diarrhea, 9% had skin problem with afatinib, and 30% patient they had diarrhea with afatinib. Osimertinib, it was less than 1% and less than 2%. So those side effects can lead to dose reductions, which can impact the efficacy. Lung 7 trial, the dose reduction were more frequent in patients with afatinib. It was 41.9% versus 1.9% in the afatinib versus gefitinib arm. While in Archer 1050, the dose reduction were to the tune of 67.4% versus 8%. And in Flora trial, the dose reduction were just 5%. So maximum dose reduction they were seen in Archer 1050 with dacomitinib to the tune of 67.4%. Similarly, quality of life assessment, the quality of life, global quality of life was maintained in the dacomitinib arm and was significantly improved in the gefitinib group, while the global quality of life was improved from baseline in both osimertinib and the EGFR TKI comparator group with no clinically relevant differences between the groups. So Flora trial showed the improved quality of life from baseline, while the dacomitinib arm in the Archer 1050, it had just stable quality of life. So should all the patients be receiving first generation oral TKI, or some patients should receive third generation oral TKI, or some patients should receive first generation and then look for T709M mutation and then go for osimertinib. So the fundamental fact behind this is that those patients who receive first generation oral TKI or second generation oral TKI, they are not able to receive, 50% of them are not able to receive the osimertinib. One third drop, one third will die during first line treatment, one third will not be eligible for any tissue biopsy. And out of those one third, 50% will have the positive T790M testing, and hence the only 3 out of 10 patients they will be eligible to receive EGFR TKI osimertinib, and 7 out of 10 patients who start on 1 or 2 generation EGFR TKI will not be able to receive osimertinib in the second line, and not possible to predict who will develop T790M resistance. So coming on to the real world evidence of T790M after afatinib, this was in Japanese study. 43% patient acquired T790M mutation. In Taiwanese study, 48% of the patient were re-biopsied, and they acquired T790M mutation. And in another Taiwanese study, 28 afatinib treated patients, T790M was identified in 32% patients. And hence, less than 50% put on afatinib would acquire T790M mutation, and these patients will be eligible for getting osimertinib in the second line. So it is imperative that we start our patients on first line osimertinib rather than on first line first generation oral TKI or second generation oral TKI. So the sequencing of EGFR TKI, starting with the prior generation EGFR TKI and then treating those that develop T790M with osimertinib, this is not optimal because we are not smart enough to figure out which patient will develop EGFR T790M. Not everyone will be well enough to receive additional treatment. We know that 30% of the patients, they do not receive any subsequent treatment. Tissue biopsies and liquid biopsies, they are not always successful to gather information on T790M mutations. And the osimertinib is associated with significant survival benefit in the first line therapy. So when the drug with the which is available in the first line and showing overall survival benefit, why not to start that drug on the first line? And these are some of the uncontrollable factors in sequencing: toxicity to the drug, occurrence of T790M mutation, sites of progression, concurrent comorbidities, and patient choice. Sometimes the site of the progression would be brain, and in those cases, it becomes very difficult to offer these patients second line treatment, because the PS of the patient frequently deteriorates very soon, and hence all of these factors, they are uncontrollable factor in the sequencing strategy. Coming on to the real world data with first line osimertinib, there are two studies which I will be discussing. First is Flower study and other is OCFACT study. So Flower is first line osimertinib in the real world, an integrated prospective study. This was done in Italy in 9 centers from 2018 to 2020, and first line patients who had metastatic EGFR mutant NSCLC, they were included. All the patients, they were white and the median age was 68. Adeno-CA were 120 patients. 3 patients had squamous cell carcinoma. PS of the patient was better than or equal to 2, and the brain metastasis at baseline was present in 30.2% patient. While the brain metastasis in the Flora trial, it was present in 16% patient. So this real world evidence for the brain metastasis as well. We can see the time to treatment discontinuation was 25.3 months, and the median time to treatment discontinuation was better in those patients who did not have any significant symptoms at diagnosis. Well, it was worse in those patients who had significant symptoms at diagnosis. And median time to treatment discontinuation was more in those patients who had less than 3 sites of metastasis as compared to those who had more than 3 sites of metastasis. Median PFS in patients with or without brain metastasis at diagnosis was 13.3 months, and the median PFS with or without symptoms at diagnosis was 15.5 months. So this was those patients who had brain metastasis. And this was the diagnostic pathway which was followed in the Flower study. The patient who had progressed, they had, from the biopsy to the pathological report, the median time was 7 days. From the pathological report to EGFR mutation testing, the median duration was 8 days, and EGFR mutation status report to start of treatment of osimertinib is 17 days. I think in our clinics, we are doing a better job than this. We can start our patients on osimertinib in just 3-4 days with the help of PCR if we are doing. And then they analyzed the molecular analysis was done to see which kind of resistance mutation was developing. So the MET amplification was very common, followed by MET amplification and EGFR mutation, and then EGFR amplification and HER2 amplification. Coming on to the toxicity in this real-world study, it was surprising, and it was surprising to me that 7.9% patient developed venous thromboembolism. So this is one of the very, very important things which we have to remember while we give our patient osimertinib. But it was there was no difference in the rate of venous thromboembolism as per age, PS, comorbidity, and tumor load, and no difference in the survival outcome was observed according to the age, comorbidity, and type of EGFR mutation. This is another study, OCFACT study, as a first-line treatment for advanced EGFR mutant positive NSCLC in real-world setting. It was conducted in Japan, 538 patients from 2018 August to December 2019, all first-line mutant EGFR NSCLCs. Median age was 71, adenocarcinomas 98%, and 0.7% patients were squamous cell carcinoma. Brain metastasis at baseline was present in 31% patients. And the median PFS, this study also confirmed that it was 20.5 months, and median time to treatment failure was 19.1 months. So median time from start of the treatment to the onset of the adverse effect was 56 months. 12% patient, they develop pneumonitis. So this is also very important that we remember that two important side effects which are non-hematological or non-dermatological are pneumonitis and venous thromboembolism, which we can see. Venous thromboembolism to the tune of 7.8%, and the pneumonitis is to the tune of 12.8%. And in the lower side of the diagram, you can see a pie chart for those patients who discontinued the treatment. This is another study, Mykonos study, real-world study of the patient with EGFR mutant locally advanced or metastatic NSCLC, which also found the similar results as that of the previous studies. So coming on to the guideline, the NCCN guideline 2023 clearly states that the osimertinib is the category 1 preferred option for the patients with EGFR mutant NSCLC. While the other drugs are also category 1, but the osimertinib has been given the preferred option. So the therapy for stage 4 NSCLC with driver mutation, these are ASCO guidelines. If the sensitizing EGFR mutation is present, osimertinib monotherapy should be given, or the other treatment which have moderate strength of recommendation are gefitinib with doublet chemotherapy, dacomitinib monotherapy with afatinib, erlotinib plus ramucirumab, erlotinib bevacizumab, monotherapy with erlotinib, gefitinib, or icotinib. So these are the moderate strength of recommendation, while osimertinib is the strongest strength of recommendation. So coming on to the summary, osimertinib is the only EGFR TKI which has demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of the greater than 3 years sets a new benchmark for osimertinib and provides a window of opportunity for management of the patient with stage 4 NSCLC. FLORA is the first line EGFR TKI that has translated PFS into the OS. Nearly 30% patients they remained on osimertinib at 3 years, and this is the only drug which is able to penetrate the blood-brain barrier and improves the patient with brain metastasis and T790M mutation. It is the safest and the least toxic drug, and sequencing cannot be considered as the best strategy, as almost 70% of the patients they are not eligible to receive second-line treatment. This is the prescribing information. Thank you so much for your patient listening.
Thank you so much, sir, for a wonderful presentation. So as we all know that osimertinib is really a wonderful drug, and we all have used in many patients, and I am sure that most of us have good experience. So this is one question that I would like to ask is, now that the FLORA2 data is there, and we know that osimertinib combined with chemotherapy it may become a new standard of care because of the good PFS data result that it has shown. So I wanted to ask that as of now, suppose tomorrow you get a patient of metastatic lung cancer who has EGFR mutation positivity, would you consider to go for osimertinib plus chemotherapy, or have you already practiced that in any patient?
So I have not started practicing EGFR TKI with chemotherapy. I think the side effects, there were quite a lot in that trial, FLORA2. Although I know that the PFS was significant, but I think that we can achieve with the help of the sequencing as well. Means earlier use of osimertinib followed by chemotherapy, and then why to expose the patient to the side effects of chemotherapy for 18 to 20 months, which can deteriorate the quality of the life of the patient also. So I have still not started. Have you started practicing in any of
No,
the?
sir, not yet. I have not gotten the patient yet. So probably if I have to happen that patients, then probably I would like to start. Not so far. And sir, any in your experience, is there any particular side effect profile of osimertinib that you might have experienced?
I have seen the pneumonitis with it.
Okay.
So although I have not come across thromboembolism, but pneumonitis I have seen with that.
Okay. Okay, sir. Sir, thanks a lot, sir, for the wonderful presentation.
Thank you, Dr. Kapil.
Okay. So next, I would like to invite Dr. Aparna Dhar, who is a consultant medical oncology in Max Super Specialty Hospitals, Saket. Ma'am, the topic that we'll be talking about is the biomolecular testing in carcinoma lung. Over to you, ma'am.
Hi, good evening, everybody. Just a small correction. I'm not a medical oncologist. I am a molecular geneticist.
Oh, I'm so sorry, ma'am.
All right.
But
No
we do know, ma'am, occasionally we have some patient of, genetic testing result coming positive, whom to refer to. We know that,
Yeah.
ma'am.
Okay. Now you guys have a tough job, so I'm not even going to pretend to be one. But thank you so much for having me here today, and I've got quite the task set for me. So without further ado, let's get started. Very basic. What have we learned about lung cancers, and particularly our NSCLC subtype? So we've actually learned that it's possibly one of the most molecularly diverse cancers, and just look at how we've evolved, right? We've gone from treating NSCLC as one large cohort in this homogeneous group, and slowly we've moved on to categorizing it based on the histological subtypes. And now from there, if you look at the adenocarcinoma subtype, it is molecularly very diverse. And I also want to draw your attention to more than one oncogenic driver mutation, which I've said constitutes for around 3%. Keep this number in mind because I'm going to revisit it in a bit. So what does our landscape actually look like? This is what the NCCN recommends. You know, we've gone beyond EGFR, ALK, ROS. We've got a plethora of biomarkers. And interestingly enough, it's not just limited to adenocarcinoma, even a squamous cell carcinoma. And now even in early stage, you know, a minimum of EGFR, ALK, ROS is recommended, and especially since we know that the presence of any of these oncogenic drivers, it is contraindicated in immunotherapy. So let's very quickly review what is our sample type that we look at for molecular profiling. Tissue is the gold standard, no argument there. At diagnosis, you do a biopsy, at diagnosis, you do a biopsy. At progression, you do a biopsy, preferably from the new metastatic site, and the sample gets analyzed. But the ground reality is we want our blocks to look something like this and have some sort of tissue, something in it. But unfortunately, tissue is becoming an issue. And so to combat that, yes, a lot of us working out of Rajiv Gandhi, Max, we may not face that much of an issue just because of the quality and the processes. But if we go into the second, third tier cities, we are seeing that, everybody's not following the standard guidelines, because of which tissue is an issue. So to combat tissue being an issue, liquid biopsy is a really good alternative. So you are essentially isolating the circulating tumor DNA, which is the ctDNA, from the bloodstream. ctDNA is essentially the somatic DNA that is released from the cancer cell into the bloodstream. And this ctDNA is isolated and molecular tumor profiling is done. Now, some of the key concerns that we've all had with respect to liquid biopsy is its concordance with tissue biopsy. In fact, studies like SLIP, NILE, PEN2 studies, which are specifically for these lung biomarkers, have very beautifully illustrated that a liquid biopsy isn't inferior to tissue biopsy. And also, some pros with respect to liquid biopsy is that you can monitor you can actually monitor treatment responses. You can detect those resistance mutations early, and you tackle this key issue of tumor heterogeneity. And keeping all that in mind, in 2021, the NSCLC consensus statement, which was led by Dr. Christian Rolfo's group, we were kind of reminded of the key differences between tissue and liquid biopsy, especially in lung cancer. So with tissue biopsy, of course, you get the cancer diagnosis and the pathology information and an assessment of markers like PD-L1 that are non-genomic. However, I do know there's some really good studies happening in the realm of circulating tumor cells, in reporting PD-L1, but that's we'll talk about this that's a talk for another day. So tissue biopsy, we do know, takes a really long time for the results to come. And it's also challenging to repeat biopsies, and it's not always reflective of tumor heterogeneity. Whereas liquid biopsy is found to be highly concordant, fast, minimally invasive, and easy to repeat, and perhaps better to capture tumor heterogeneity. Although, unfortunately, while all our patients cannot afford a Guardant or a Foundation or a Tempus, a lot of our domestic partners, some do some really good quality work and some do not do the best quality work. So we are seeing that, liquid biopsies sometimes are not sensitive, especially when it comes to our more homegrown tests. And that's where we tend to see a problem between tissue and liquid. So what would be our ideal profiling strategy? Now, in continuation with NSCLC, in 2021 consensus statement, it was observed that the treatment-naive patients, there were at least 3 approaches that were recommended in liquid biopsy. One is a sequential approach, which is tissue failed, and then you do a liquid biopsy. The second is a complementary approach, tissue liquid done together upfront. And this is something that we're very slowly moving toward. And third is plasma first approach. Now, if it's clear that you aren't going to have sufficient tissue, surgery, biopsy, etc., is not an option at all, and the tumor is inaccessible, do plasma upfront. However, if the plasma does come negative, don't just assume that it's a true negative. They do then recommend as a reflex doing a tissue biopsy. Now, there are many technologies that are available to call out these mutations in these biomarkers, but NGS is our platform of choice, and not just mine. I think it's fast becoming everyone's platform of choice, and we're not belittling the standard of care like RT-PCR, FISH, IHC, but I feel with NGS, we kind of get the answer to the biology of the tumor in one sitting versus the standard of care platform. So in addition, where it's really proving to be, the front runner is that it's cost effective, improved TAT, you've got tissue preservation. And for me, the most important point is that you have the potential to discover actionable targets. And you remember the 3% I spoke about earlier, where you could have more than one oncogenic driver mutation? NGS calls it all out in one shot. So what this does, it helps you guide and chart out a more personalized treatment for our patient. And here's actually data from my cancer genetics clinic. Approximately 40% actionability is there in these biomarkers, but these concomitant mutations that we see actually help guide better treatment. We know, EGFR in different exons have a different response. EGFR with TP53, we know we need a chemotherapy arm. So, you can make a lot of decisions based on when you have the entire picture versus just part of a picture. Now, to further prove my point, I'm actually going to seek the help of two biomarkers that I personally think that we're all very comfortable with, EGFR and ALK. So in an unspecified, unselected population from there, you've identified an EGFR mutation. Classically, you start your patient on a TKI. After a period of time, the patient is going to develop a resistance. So you again, use imaging to confirm. Then for the new metastatic site, you take a biopsy sample or you send it in for a liquid biopsy, irrespective of sample type. You do repeat molecular profiling on progression. And at this point, there is a 60% chance that we know that the most common resistance mutation in EGFR is the T790M, and that's what you're most likely to detect. However, in addition to this, we also have a host of other resistance mutations. You've got your MET amplifications, you've got your PIK3CA, HER2, and more importantly enough, you've got the small cell transformations, and all this can be identified with NGS as your platform of choice. Similarly, when a patient progresses on osimertinib, it actually acquires resistance mutations. And again, we saw this in the AURA3 trial, and we just heard Dr. Manish talk about it too, is that around 15% of patients actually get a C797X mutation, and then there is about 19% they get a MET amplification. HER2 is around 5%, and all these mutations can be reported in one go using NGS as your platform of choice. Similarly in ALK, once a patient progresses on first generation ALK, you want to understand which point mutation, which fusion has it has been acquired. Like we know the G1202R is a known resistance mutation to crizotinib, which means you need to look at lorlatinib on another second generation ALK inhibitor. So all of this, what it does is NGS helps identifying and increasing matching your patients to targeted therapies. And here's actually a snapshot of the available biomarkers that, with their associated therapies. There are new additions. Yes, I've highlighted EGFR, and there's a logic behind it. There's a slight change how we look at EGFR now. You've got your NTRAX, RET, MET, KRAS 12C. So very quickly, let's just talk about them. So why have I put EGFR? Now, EGFR are broadly classified into three major categories. The first one is those very classical sensitizing mutations, as we know very well. Your exon 19 deletions, your L858Rs, very common. And the second is these atypical uncommon mutations, the G719X, the L861Q, your S768I. You've got your EGFR, and then the third one is your EGFR exon 20 exon mutations. Now, If you very quickly take a look at these so-called uncommon mutations, which actually aren't really very uncommon, because as we've increased testing and we are kind of testing the entire EGFR gene, we're no more looking at just hotspots, we are seeing a lot of them, and these are very unique. The G7, the G719X, these exon 18s, these are sensitive to is an exon 18. Then you've got your S768I, which is an exon 20, the L861Q in exon 21. These point mutations are actually sensitive to your first generation TKIs. And in fact, G719X is even sensitive to afatinib and neratinib in particular. And what we see a lot with these EGFR mutations is that we see them concomitant. We see these two mutations together. So G719X is usually seen with L861Q. And G719X is also seen with S7681. And these have a higher sensitivity to TKI, but they're also associated with a poor prognosis. And when we look at the entire EGFR tyrosine kinase domain, your exon 18, as we've seen over here, actually is from the amino acids. The codon regions are 688 to 728. And your G719 obviously falls in here. It's around 2 to 4%. Now, interestingly, what we see in this particular domain is that you see alanine, serine, and cysteine, or even aspartic acid in this position of these glycine residues. That's what makes it responsive to your TKIs like afatinib. The P-shift loop, is the one that actually hinders the binding off with osimertinib. Thus, that's not the most ideal drug for these particular mutations. Exon 19, pretty straightforward. It's from amino acid 729 to 761. They're around 45% of your deletions. Exon 20. Now, this is quite the curveball, and they're kind of very different and very, very unique. And while your T790M falls in there, a lot of your other mutations, your insertions are, they constitute for around 1 to 10% of these cases. And then we move on to exon 20, which is around from codon 824 to codon 875. And again, we see the LA5ATR most common, 45%, but that L8Q61, the L8Q61Q that we see, the L861Q, sorry, that we see, it's usually seen concomitantly with some other uncommon mutation. So what really makes this exon 20 insertion so unique is that, first of all, it's not uncommon. It constitutes for around 12% of your EGFR cases. But what you can really see where this, for me, really stands out is the fact that exon 20 is obviously in the tyrosine kinase domain. It's in the same place where you've got your 19, 20, 21. But exon 20 codes for this entire region of the C helix and the loop that follows the C helix. So if you see over here, exons that are coding from amino acids 761, 2, 3, 4, they all are so on and so forth. So with advancement of technology, what's happened is that these specific alterations are shown to be responsive to specific treatments. So it's not just knowing it's an exon 20 insertion, you need to know the codon. So amino acids 763, 764, if there's an insertion over there, if it's altered, these are the ones that show sensitivity to first generation TKIs. And it is from 766 to 770 that you show response to something like poziotinib. And similarly, between 773 and 774, it is to afatinib. Thus, reporting it as a standalone is not important. You're just seeing an exon 20 insertion is not the only thing. You need to know the exact codon. And the reason why these behave so differently versus the general, the common EGFR mutation is due to the fact that the structure is such that they reduce the drug binding pocket and the affinity for most TKIs that are indicated, for the most TKIs indicated for common EGFR mutations. So when the size becomes smaller, the drug interaction becomes less. That's why they don't respond very well. And what makes these even more interesting is that there are certain mutations that you see, the V769, D770 in 65 and above. However, V763 to V764, we see them and 773, V774, we see them in less than 65 years. Again, you've got a couple of mutations that are synonymous with never smokers and with women. And these, interestingly enough, there are these mutations are associated with features characteristic of true oncogenic drivers, including the infrequent co-occurrence of other driver mutations, and they also are known for having a very low TMB. Now, let's move on to NTRK fusions. We know that these are very, very rare. They constitute for around 0.3% of all NSCLC cases. These are agnostic markers. These waterfall plots for entrectinib and larotrectinib illustrate a majority of solid tumors, lung cancer included, responded well to TKIs. Now, the rearrangement of NTRK gene, what it does is it couples with the tyrosine kinase domain with a 5' fusion partner to generate a chimeric TRK protein by ligand binding domain. In short, what you get is a fusion, and common fusions that we see in lung cancer are NTRK with TPM3, NTRK3 with ETV6, to name a few. Now, this flowchart is the testing method that is recommended by ESMO, but in my very, very humble opinion, I think NTRK fusions, they're essentially translocations of 1, 2, or 3. NTRK3 has a low staining on IHC, whereas NTRK1 has a low sensitivity and specificity to fish. So the preferred platform is NGS, and that though RNA NGS, because they're fusions, amino RNA NGS for fusions increases the sensitivity and specificity, and the same is being echoed in multiple international publications too. RET fusions. Now, RET we know is synonymous with papillary thyroid carcinoma, but it constitutes for around 1 to 2% of our NSCLC cases. And RET genes are essentially what's happening here. It's a rearrangement which gives rise to these chimeric cytosolic proteins, which constitutes and activates the RET kinase domain. KIF5B is the most common fusion partner that we see in our NSCLC cases. Again, fusion, RNA, NGS. Therapy option is selpercatinib from the Libretto 001 trials and pralsetinib or Blue 667 from the Arrow trials. We've then got the MET exon 14 skipping. Now, this is essentially a mutation that occurs at the junction of exon 13 and exon 14, and the product is essentially a fusion of exon 13 with exon 15. Again, take it as a blanket thing. Anytime you're doing a fusion, you're looking for a fusion, be it for ALK, be it ROS, be it for any of these, it's always RNA NGS. So if your NGS report comes back negative, go back, ask your service provider, did they do RNA or DNA NGS? If they've done DNA, I very strongly urge you as a reflex to do RNA NGS too. You could be missing out on potential fusion partners. And in the case of MET, your treatment options are crizotinib from the Profile 1001 trials, capmatinib from the Geometry trials, and tepotinib from the Vision trials. Then we move on to KRAS. Now, KRAS mutations we know are the most common mutations. In NSCLC, they constitute for around 25 to 33% of our cases, especially in our smoking cohort. And interestingly enough, these are mutually exclusive with EGFR and ALK mutations. What happens over here is a GTP binding protein. It connects the receptor of the TK, the RAS, which sends activating signals to a number of cellular pathways it's involved in, which leads to cell proliferation and survival. And from this KRAS subtype, G12C is the most common. It constitutes for around 40% of the KRAS cases. And it's also a poor prognosis versus obviously a wild type KRAS. What's interesting in this particular subgroup are the varying TMB rates. The G12 has a high TMB rate followed by G12C, and G12D has a propensity for low TMB. Vis-a-vis, when we look at the PD-L1 TPS scoring over here, G12C has a higher one and G12D is slightly lower. It's just very interesting. These are point mutations. You can use DNA NGS. And the trial that was there was the AMG 510 trial. So Sotorasib is your treatment option of choice. Very quickly, talk would be incomplete if we don't talk about immunotherapy from the Keynote 010, Checkmate 017, Oak trials. Time and again, the utility of PD-L1 testing has been demonstrated. That's making it a recommended biomarker upfront. We have various TPS scores and cutoffs, which sees if a patient is a candidate for immunotherapy. The second biomarker, and for me, this is slightly controversial in lung cancer, is tumor mutation burden. The key concept over here, the key theory behind this is that every cancer has a mutation. The more the mutation, higher the neoantigen load and possibly a better immune response. So in a lab, on a minimum of a 250 gene panel, you look at the number of genetic aberrations in the genomic region, in the exonic region. And this gives you an indirect idea whether or not the tumor you're dealing with has a high neoantigen load or low neoantigen load. However, here's where I think there's an issue with this particular theory. Not every mutation will cause the tumor to have a neoantigen, and they may have the antigens, but it may not necessarily be a neoantigen that is going to be recognized by the immune system. Thus, the neoantigen may not really induce an immune response that we're looking for. Different studies, different cutoffs for what they consider TMB as high. So what do we do in this particular case? I don't think it's a one-size-fits-all cutoff, like, you know, how PD-L1 has different cutoffs. However, from the Keynote 158, FDA has given us approval. So tread carefully. Foundation possibly has the best data where it comes to TMB scoring. If not Foundation, then maybe the assays from Thermo Fisher, which looks at TMB. They do have a couple of white papers, but again, tread carefully. So long story short, after all of this, what do we do in our clinic? Upfront, when a patient comes in, we try and go beyond the 5-gene NGS lung panel. We kind of do the 20-gene NGS panel with a PD-L1. Ideal situation, we do like to do tissue and liquid upfront. What we have learned is actually having a conversation with a patient and explaining the logic. Everybody wants to circumvent doing chemotherapy. So having that conversation with a patient that, look, if your tissue is negative, it is advisable that we do liquid. If both are negative, then chemotherapy. But there is a possibility if one sample type misses, the other one picks it up. It's option one in treatment naive. Now on progression, at this particular point, or in a case of recurrence, what we would like to do, take a tissue sample from the new metastatic site. If that's not possible, send a liquid biopsy here to address the issue of tumor heterogeneity. Ideal situation, utopian world, you want to do tissue and liquid together. I do know the gold standards are Foundation, your Guardant, and your Tempest, but for those of the patients who can't afford, do look at Thermo, and Illumina has some really good, well-validated panels. Domestic partners ensure that they've got good validation data before you start, just sending out a sample for testing. And if PD-L1 is not done at this point, I would do PD-L1 and then go for a much more broader panel because I want to look for all my resistance mechanisms over here. And just to summarize, these are 2 cases that I have, and I'm going to call it a day. And this is just one case of a 50-year-old female non-smoker. We did sequential testing, came back negative. At this point, we sent it for an NGS. The NGS picked up a BRAF mutation. So obviously, you have a chance of picking up more actionable mutations using NGS versus the standard of care sequential, RT-PCR, IHC, FISH, etc. Second case, 79-year-old male, EGFR positive, started on afatinib, progressed, rebiopsy from the new metastatic site. No mutation detected. At this point, we were still suspicious. 79, 80-year-old did not want to start him on chemo. So we did a liquid biopsy and we picked up a MET exon 14 skipping mutation. Now the VAF over here is around 0.4%. So in liquid biopsies, because the depth of coverage is around 15,000 to 20,000x, when you increase the depth of coverage, you're increasing the sensitivity and specificity, especially for calling out these really, really small, mutations. And obviously, due to tumor heterogeneity, you're not going to pick up something at 0.4% VAF on a tissue. And this patient was started on capmatinib. And my third case is an 81-year-old female, NSCLC. Tumor was insufficient. We sent it for liquid biopsy. She had a ROS1 mutation. She was started on crizotinib. She eventually progressed. We did a liquid biopsy because she just refused to do a tissue biopsy at this point. ROS1 fusion was persistent, but she had acquired a ROS1 G2101A. As I said earlier, it's a known resistance mutation to crizotinib. It's acquired. She was started on lorlatinib. Unfortunately, it was short-lived, so she progressed. We did another liquid biopsy. The ROS1 fusion was persistent, but she had lost the G2101A, but had gained a ROS1 G2032R. In addition, if you see, she had a KRAS 117N, and now she had gained a KRAS 12D. So she lost the other one. It was a KRAS 12D. And we know binimetinib, and this patient could get it through, this patient was getting the treatment in the US. So they had access to binimetinib, but this is where you have to be very careful of a phenomenon called CHIP mutations, especially with liquid biopsies. So when you're doing a liquid biopsy, it's not just a cancer cell, you're also going to be getting the aging WBCs. And these have been identified as clonal hematopoieses of indeterminate potential, CHIP mutations. It's a very long-winded thing, so we call it CHIP. And these are not uncommon, and especially in our lung cancer patients. Those who are older, our patient was 81 years old and has a history of smoking. Some of the common CHIP mutations that we see in lung are TP53, KRAS, and JAK2. So if you see something which has a VAF less than 1%, go back, double check with your lab to ensure that it is not a CHIP mutation. And I think this pie chart best summarizes my talk. Around 50% of our patients with advanced NSCLC have a driver mutation that's targetable with an FDA-approved agent or something that's in a clinical trial that's here in red. And on that note, thank you very much for your patient listening.
Hello. Thanks a lot, ma'am, for the wonderful talk. So this was really very good to learn so much about the biomolecular testing. It is an area where many of us are confused between different testing modalities. So just a small question I have. So nowadays, that the availability of NGS is increasing, and many of our patients are getting NGS testing done. So in those cases, we do get HER2 positivity, and we also get amplification is usually, amplification is also included in the NGS testing. So suppose if a patient comes, NGS report comes as HER2 negative, that is not identified, do you still try to go for the IHC testing, or that you take it as HER2 negative?
So that's a very, very good question. It really depends what sort of a test has been done and what the NGS is. So let's say this is an NGS which has RNA and DNA. So the HER2 fusions will be caught, the point mutations will be caught. All of these mutations will be caught on that NGS, and I'd be very, very comfortable just proceeding. Now, if the service provider has just done DNA NGS, and considering that the targets over here are more HER2 point mutations versus the amplifications, if you're looking at those 20 exon 20 insertions, I would be quite comfortable with the NGS in lung cancer. Let me just be very clear, in lung cancer. Amplifications can be a little dicey at sometimes, so you've got to be a little careful and tread very, very carefully.
Okay. And do you also think that HER2 positivity in the lung cancer that imparts some resistance to immunotherapy or EGFR? Now we have data that HER2 positivity, so these patients may be resistant to anti-EGFR therapies, but do you feel the same about the immunotherapies also?
There's no data, to be very honest. I've not seen it being contraindicated, so I don't want to make a blanket statement, yes. But I think the more we test and the more we understand the correlation, we will figure out that is it going to be a resistant or contraindicated immunotherapy? At this point, I'd say no, but I think more work is needed.
Sure. Thanks a lot, and very insightful to know. Okay, so next I would like to invite Dr. Ishu Gupta, who is a consultant medical oncology in Cancer Center, and who is also a visiting consultant medical oncology in Fortis Cancer Institute, Noida. Dr. Ishu Gupta will be talking about overview of lung cancer. So here we will be learning a bit about basics of lung cancer, how to diagnose, what symptom, how to take the sample, and basic treatment. Over to you, Dr. Ishu.
Hi, can you hear, and is my slides visible?
Yes, sir. You are audible and your slides are visible.
And I'm not able to see them in full screen. Is it full screen, right?
No, it's not full screen yet.
It's not yet. Okay, I think it's
now it's full screen. Yeah.
So thank you, everybody, and just excuse me for the video, please, because I am using my cell phone network and it might get shut down there.
No problem.
So great. After a wonderful and insightful talk by ma'am and Manish sir, also some fancy terms and fancy testing, all those new drugs. That is, what we want to hear when we spend our 30 minutes of time. I have been given a topic that is an overview of lung cancer. So we'll be talking of really basics and just going through what we already know probably, and maybe highlight on certain points that we do in our routine practice to reach a point where we can, send the tissue for the biopsy, or, make a decision of do we really want to declare this patient palliative versus a curative surgery. So we all know that lung cancer is one of the common cancers, being the second most common cancers in males and the fourth most common overall cancer overall. So we have about 70,000 odd new cases each year which are diagnosed with lung cancer, and out of which we see, unfortunately, about 60. Most of the patients that are getting diagnosed these days, at least as of now, the same number of are dying, and we are improving on these statistics as the science advances. One very important slide I want to put here is the change of staging of lung cancer. So whenever we read data from previous trials, from meta-analysis, less meta-analysis, is the patient qualifying for chemo? Is it not? So they would usually say that patients who were stage 2B, they qualify for chemotherapy, but stage 1B does not. But we have to understand that the time the paper was written, AJCC 7th or 6th guidelines were being followed, and we have to restage them according to the same guideline. We can really see here that a tumor which was, say, around 6 centimeters with an N1 node was stage 2B as per AJCC, and a 6 centimeter tumor with the N1 node is now a stage 3A tumor. So similarly, a lot of changes have come up in the AJCC 8th division, 8th edition, with sizes being changed, the invasions being changed, the nodal status is being changed. So we should be careful about which system was used in which paper. So a very important tool for staging is bronchoscopy, CT chest, PET-CT, EBUS, mediastinoscopy, and patients do inevitably require an MRI brain too. So what about CT chest, abdomen, pelvis versus a PET scan in a stage 3 or say in a stage 2 also non-small cell lung cancer? So we say that patients on a CT which have a 10 mm long short axis diameter, they are probably malignant. But then CT alone has a very low sensitivity per se, which is about 55%, and a low specificity of 80% in diagnosing malignant tissues. Although the biopsy of each tissue is always the gold standard, but we hardly are able to, biopsy each node. We would maybe biopsy the primary, maybe a node, but that's it. That's about it. But to identify which node to biopsy and to have a good positive predictive value from that, I think a PET-CT does help us a lot there, which has a high sensitivity of 90% and a specificity of, again, to the tune of 90-95%. And guidelines are very clear there that, this is pathology and molecular biology. We'll come back to this. But as many as 62% patients, the PET staging can change the stage. If we use a PET versus a CT, there are studies which say that in about 60% of the patients who have a locally advanced lung cancer, they may change their stage with a PET. And in about 50% patients, the management could also change. Maybe we were taking up for a surgery, but a PET identifies an N2 node, and the patient goes in for either neoadjuvant chemo or a CTRT. So there are certain predictors on the PET-CT which say that, an occult N2 can be identified with a positive predictive value on a PET-CT scan. One of them is the tumor being central. The other is the clinical size of the tumor on the PET. So in case we have a tumor which is around 6 centimeters, there is a chance that 6% chance, 1 in 16 patients would have an occult N2 met. But if tumor is more than 6 centimeters, we don't see anything on a PET. We should be very careful and think that, okay, there is a 4 in 7, that is a 57 staggering % chance that we have missed something, and there is an occult N2 met. Also, an SUV is a good predictor of an occult N2 met. So if the primary has an SUV of more than 4, we should say that maybe in 10% of those patients with a negative PET on the node, we are missing the occult N2 met there. So we should keep in mind the size, the location, and the SUV on the PET scan. And then comes in what patients do you need a EOS or a EBUS biopsy, or more so, though we hardly do it nowadays, mediastinoscopy, which is an invasive biopsy. Mediastinal staging, the recommendations are very clear, EBUS and EOS. are the preferred modality if we can reach the node there. But if not, then mediastinoscopy is definitely recommended from either of the nodes. Here I would like to point out that EBUS has a very good positive predictive value if we have a positive result. But in case there is a negative result on an EBUS2, the negative predictive value there is 90%, and there is a good 10% of patients which we are saying that are node negative there, but could be node positive there. So they might help from the invasive mediastinal staging there. So guidelines are again clear that once we have a patient suspected with NSCLC, you go ahead and do a contrast CECT. However, we kind of in clinical practice kind of jump the first step, and sometimes if there is a high predictive value, high suspicion of a malignancy there, we straight away go ahead with PET. Maybe the costs are low in our country, or maybe just to avoid an extra imaging. So if the CT is negative, it's clinically stage 1 and 2 as per the guideline. You go ahead and do a PET. If we have a peripheral tumor in which the PET is negative for the node, it says that no further mediastinal workup is necessary. But in case it is a central tumor and the PET is negative, it's always advisable to go ahead and do either a VATS, or preferably what we do more commonly is an EBUS or an EUS. If the PET is positive on the for the lymph nodes or the N2 nodes, a tissue confirmation is required there. That's again very important, because saying that if there's a 4-centimeter tumor with an N2 node, we would say that, okay, you are not a candidate for surgery, go in for a radical CTRT. But there would be occasional times where we would identify that node to be a tubercular node. So it is always advisable to go ahead and get the biopsy done from that using maybe EBUS, EUS if accessible. And if there is a massive N2, N3 disease on the CT chest, it clearly concludes the workup there, and you go ahead and do a metastatic workup and then complete the case. Lymph node stations accessibility, I think we are very clear. Ma'am very thoroughly talked about tumor biopsy advantages of a liquid biopsy versus a tumor biopsy. I would not go into the detail again, and the patients the same thing. Again, this part was mostly covered by Dr. Aparna in the previous talk, but evolution of therapy in lung cancer has been phenomenal in past, say about 15 or 20 years, where we were talking about survival rates of a few months, maybe a couple of years. We are now talking about how many more years, 5 years or 4 years of survivals in patients who have metastatic lung cancer, especially in the non-small cell lung cancer subtypes. And also with the technology evolving with our better understanding of science. Initially, we used to classify them only as NSCLC or SCLC. Then we started to classify it further, small cell, large cell, adeno. Then we started to classify them as a EGFR mutated, ALK mutated. And now with the immunotherapy coming in, a PDL expression has also started to divide the tumors, and also TMB. So a high PDL1 more than 50%, intermediate 1 to 49, or a low PDL 1% is usually written in the diagnosis if the driver mutation is negative. So as I previously mentioned, the survival rates of lung cancer have phenomenally improved over past few years, and this has been coupled with the reduction in the incidence also, because in the West especially, where the smoking rates have gone down. So the overall burden of lung cancer has been going down, especially in the Western countries. We are yet to have a reduction in the incidence, and so more likely we would see it in next few years. Again, advances in the treatment, ma'am has talked about it in detail, but 2006 we were talking about chemotherapy and bevacizumab for non-small cell non-squamous cell cancers, and now we have come to an age where you have a plethora of options ranging from immunotherapy to target to not just 1, 2, 3, but as many as 10 to 14 targets available, and then about the chemotherapy in patients who are not able to get any of that. Molecular targets, again, ma'am mentioned very clearly, not just 3 EGFR alkaros, you should test for the other mutations, including BRAF and TRK, METRET, and also see that if we have done NGS or not. And if an NGS is done, is it a DNA NGS or has it included RNA fusions also? So otherwise, we might be missing on a lot of driver mutations, and subsequently leading to less of the outcomes. To current guidelines, this is not a very updated slide here, but I would say still largely followed. Stage 1A, if you go in ahead, do a surgery, no clinical benefit of neoadjuvant or adjuvant chemotherapy. 1B, 2A onwards, with Checkmate 816, there is a role of neoadjuvant there, so this slide does not cover that. But again, there are patients who are at higher risk who should be getting adjuvant chemotherapy there. And also these patients should be tested for EGFR mutations. And now with Alina trial, maybe an ALK mutation also. 2B onwards, adjuvant therapy is usually recommended. It could be chemotherapy, it could be a hormone, it could be anti-EGFR therapy or anti-ALK. And then stage 3 onwards, again, we are very clear there that either neoadjuvant chemoimmunotherapy, yes, adjuvant chemotherapy if the surgery is already done, definitely. And in case the surgery has positive margins, sequential chemoradiotherapy. Again, dependent on the margins. If we have, one second, if we have an incomplete resection after a stage 1, patients should undergo a re-resection, which is preferred, or otherwise they should undergo radiation if it's not possible. Stage 2, again, re-resection plus chemotherapy, or it could be a sequential preferred chemoradiotherapy. And if there is a stage 3 onwards disease, the patients are definitely a candidate for chemoradiotherapy there. So even after the initial complete treatment of NSCLC, we see that more than 50% of patients do recur locally or distantly. We are improving these rates by novel therapies like Adora has improved it in patients with EGFR mutation. Checkmate has improved the outcomes after the neoadjuvant therapy, and a good number of patients getting PCR there. So the long-term outcomes are increasing, but then again, very clearly, the tumors are divided into settings of less than 4 versus more than 4 centimeters. This was done way prior around the LACE analysis time, saying that any patient who has a primary more than 4 centimeters, a chemotherapy is warranted there. Similar slide, which says chemotherapy has a good hazard ratio of 0.89 in improving the overall survival if the patients have adjuvant chemotherapy there. So how well neoadjuvant chemo works? It's probably same as, but I think this again is outdated after the Checkmate 816, which says that a neoadjuvant chemoimmunotherapy works very well. And I'm very sure that as medical oncologists, all of us have seen very good results. And nowadays surgeons are also on the same page saying that it doesn't really increase the burden of toxicity when they are operating on those patients. So this has been discussed in detail, so I would skip Adora trial. Osimertinib is one of the is the standard therapy in patients with at least stage 1B or preferably 2 onwards, an adjuvant therapy, which does reduce the risk of death by around 80%. Radiation, again, there have been improvements in radiation modalities with the technology improving from VMAT, 3D CRT, then IMRT, IGRT, stereotactic radiations, SBRT, where we are able to give about 8 to 20 gray of chemotherapy per fraction and finish therapy in probably 1 to 5 fractions. Then there is now 4D CD planning where margins around the tumor can be minimized and the radiation can be targeted more to a specific area of tumor, IGRT, adaptive radiation. So majorly and end result radiation, which is very important, where when the radiation or chemoimmuno is given along with, the tumor starts to shrink, but then eventually you end up radiating the whole field of the primary lung tumor. So with the end result radiation, they start to monitor it and keep reducing the field of radiation as the tumor starts to shrink, thereby minimizing the dose to normal tissues, lungs, esophagus, heart, and nearby structures. So again, checkpoint inhibition, it started from Pacific trial in the adjuvant settings, now has moved to neoadjuvant also. And emerging treatment paradigms we have discussed in detail in the previous talks also. Targeted therapy and immunotherapy are the kids on the which are now really practical and that we are practicing in our day-to-day practice. Other emerging molecular targets, I think they have already emerged, but metaxon, RET, and TRK, HER2, all of them are very practical, available, and most of our patients are on these therapies. And all of this has actually combined and helped us improve the survival rates from the yellow to the blues. So you see 8 months, 12 months, 14 months, that's what we were talking about a few years back, and see what we're talking about now is sometimes not reached 44 months, 39 months, 35 months and counting. So with the correct testing, with the correct molecular help, with the correct staging of the tumors and correct modalities of treatment and better understanding of the biology of tumors, we are really able to improve the outcomes and help our patients a long way. And as we discussed, immunotherapy started in 2015 and now has reached a point where it is approved in neoadjuvant, approved in adjuvant, approved in palliative, approved as single agent, approved as combination, approved as nivo-IP, approved as single agent atezo, approved with chemo. So all sorts of combinations are approved currently, but we need to identify the patients correctly and personalize the treatment there. So it's truly an era of personalized medicine, especially in the lung cancer, which is probably the poster boy for personalized medicine now. I think that's the key takeaway, that personalized medicine is the way forward for lung cancer management. But again, we should not forget our basics. When stage the patient correctly, especially in patients who are stage 2B, 3A, 3B, where we should not be mismanaging them just because thinking that it is a tumor and it could be a TB, or not thinking there is a tumor and just going in for a futile surgery. So with that, I would end. Thank you so much.
Thanks a lot, Dr. Ishu, for this wonderful presentation. So I'm sure basics are actually not so basic. So even though you might have covered the topic that was given to you was actually overview of lung cancer, but we all know we cannot deal with all those fancy names and fancy molecular and testing unless we know the basics of carcinoma lung. So the talk was very nice, and I'm sure all of us got to learn a lot by this talk. Thanks a lot for your time. So next, I will also deliver a talk in the role of osimertinib in the EGFR mutated lung cancer and the early lung cancer, focusing mainly on the ADAURA trial. So I just try to share my screen. So I hope my screen is visible to everyone.
Yes, sir. Please start, sir.
Yeah. So today we'll be talking about osimertinib in early EGFR mutated NSCLC patients, ADAURA trial. Let me just see. So the little background, as we know, the lung cancer is the leading cause of cancer death, accounting for more than 1.7 million deaths annually. And it is as many deaths as combined deaths by breast, prostate, and colorectal cancers. While talking about lung cancer, so 85% of the cancers are NSCLC, while only 10 to 15% patients are small cell carcinoma. And estimated 30% of the patients of lung carcinoma present with resectable disease at diagnosis. So, but we know that this is the Western data. In India, the figure might be actually lower and not 30%. So in the early resectable disease, we categorize them into two: localized early stage, that is stage up to stage 1B, and then regionally locally advanced, combining of stage 2 and stage 3A. So outcomes in the early stage NSCLC need to be improved because surgery is the primary treatment for such patient, and adjuvant cisplatin-based chemotherapy is recommended for patient with resected stage 2 to 3A NSCLC and selected patient with stage 1B disease. So we had less meta-analysis done, which evaluated the role of adjuvant chemotherapy in such patient, and it showed that a 5-year OS benefit with adjuvant chemotherapy was there in patient with early stage NSCLC with a hazard ratio of 0.89. DFS also favored adjuvant chemotherapy with hazard ratio of 0.84. Overall, disease recurrence or death following surgery and adjuvant chemotherapy remains high across the disease stages, be it all, any stage. As expected, the risk of recurrence at 5 years obviously lower in stage 1B, but it was higher in stage 2 and stage 3, reaching up to 76%. So, based on limited number of study, we know the prevalence of EGFR mutation is almost similar in all the stages. While taking data from US and Europe, approximately 20% of the patients have EGFR mutation, while in Asia, the number is much larger, and across all the stages, approximately 1/3 of the patients have EGFR mutated lung cancer. And if EGFR TKIs were available in the resectable setting, a similar proportion of patients may be able to benefit compared to only advanced setting. So keeping these things in mind, ADAURA trial was designed with osimertinib as adjuvant therapy in patient with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. So ADAURA was a phase 3 double-blind study in which patient with completely resected stage 1B, stage 2, stage 3A NSCLC who have or have not received adjuvant chemotherapy were taken. So the study was done in more than 20 centers of Japan and Taiwan, including patients more than 18 years of age with WHO performance status of 0 and 1. They should have a confirmed primary non-squamous NSCLC with exon 19 deletion or L858R mutation positivity. Brain imaging has to be done if it was not completed preoperatively, and patients should have undergone complete resection with negative margins. Maximum interval between surgery and randomization was kept 10 weeks if the adjuvant chemotherapy was not received, and if adjuvant chemotherapy was received, the gap should be 24 weeks, allowing for 4 cycles of 3 weekly chemotherapy. Stratification was done according to the stage, EGFR mutation, and race. So these patients were randomized in 2 arms. One was osimertinib, that was experimental arm of 80 mg once a day, by placebo arm which received the similar drug. So the planned treatment duration was 3 years, and treatment would continue until disease recurrence or treatment completed or discontinuation criterion met. The follow-up was done until recurrence in week 12 and week 24, and then every 24 weeks to 5 years, and then yearly. If the recurrence happened, then every 24 weeks for 5 years, and then yearly. The primary endpoint was disease-free survival, which was by investigator assessment in stage 2 and 3A patient designed for superiority under the assumed DFS hazard ratio of 0.70. The secondary endpoint was DFS in the overall population, and DFS at 2, 3, 4, and 5 year OS, safety data, and health-related quality of life. Following independent monitoring committee recommendation, the study was unblinded early due to efficacy. So here the reported the unplanned interim analysis result. At the time unblinding, the study had completed enrollment and all patients were followed up for up to at least 1 year. So talking about inclusion criteria, adult more than 18 years of age, primary non-squamous histology with post-operative stage 1B to 3A, central confirmation of EGFR mutation, standard post-operative adjuvant chemotherapy consisting of a platinum-based doublet for 4 cycle maximum is allowed, but it was not mandatory. So some patients received adjuvant chemotherapy, many patients did not receive adjuvant chemotherapy as per the surgical treating team discretion. Complete surgical resection had to be there with primary NSCLC and recovery from resection surgery. Treatment will start no earlier than 4 weeks following surgery. MRI CT scan of the brain had to be done. WHO performance status of 0 to 1. Patient who had received pre or post-operative radiotherapy or pre-operative chemotherapy, any kind of EGFR TKI or CYP3A4 inhibitor were also excluded. Time between surgery and randomization not more than 10 weeks or 26 weeks, depending upon whether chemotherapy was also received. Patients who have had only segmentectomy or wedge resection were excluded. Cardiac criteria, including factors that could increase the risk of QT prolongation or any arrhythmic event were excluded. Any evidence of severe or uncontrolled systemic disease or any history of ILD or other malignancies were excluded. Here in this table, we can see the baseline characteristic in both the arms. The in proportion of stages was similar when ADAURA patient was restaged by AGCC addition manual. So most of the patients were female, 72%, and the median age was 64 years. 2/3 of the patient were non-smoker, while 1/3 patient were smoker. Most of the patient were Asian. AGCC staging and diagnosis we take by 8th edition. So 1B, 2, and 3A were equally divided between among the three stages, and histology 97, most of the patients were adenocarcinomas, and EGFR mutation, exon 19 deletion, and A858R mutation were equally divided. 60% patient received adjuvant chemotherapy, while 40% patient did not receive any kind of adjuvant chemotherapy. If we look at the ADAURA updated primary analysis in stage 2 and stage 3A, the median DFS was 66 months with the osimertinib arm, while it was only 22 months in the placebo arm, with the hazard ratio of 0.23 with confidence interval of 0.18 to 0.30. Maturity was 51%, and osimertinib arm it was 32%, while in placebo arm it was 70%. If we look in overall population, the similar efficacy is maintained with the median DFS reaching 66 months in osimertinib arm versus 28 months in the placebo arm with a hazard ratio of 0.27. If we look at 4-year DFS, it was consistent for the osimertinib arm across disease stages. So in stage 1B, the placebo arm had 4-year DFS of 59%, which was increased to 80% in the osimertinib arm. In stage 2, 42% versus 74%. In stage 3A, it was 14% versus 65%. So if we look at the hazard ratio, it was 0.41, 0.34, and 0.20. Looking at this data, it is clearly see that the maximum benefit was reached in stage 3A patient rather than stage 1B patient. So maximum benefit of osimertinib was in the higher stage patients. If we look at the forest plot, we can see according to the subgroup, the benefit of osimertinib was maintained across all subgroups with the across sex, male and female, age less than 65 or more than 65 years, according to the smoking history, race, stages, EGFR mutation or adjuvant chemotherapy. Across all subgroups, the benefit of osimertinib was maintained. Across all stages, 1B, 2, and 3A, we see the 3A patient had disproportionately higher benefit. Benefit was more in exon 19 deletion. It was slightly lesser in L858R mutation patients. If we look at the overall survival, although the data is not mature and the median OS is not reached in either arm, the hazard ratio is 0.40 with a confidence interval of 0.18 to 0.90. Maturity is only 5%. Patient and investigator remain blinded to treatment in order to facilitate assessment of OS at maturity. So if we look at the adjuvant therapy data with other earlier generation TKI, so we had multiple trials like SELECT trial, the RADIANT trial, EVAN trial, adjuvant CTONG 1104 trial, and BR.19 trial. They were done across the globe in multiple other countries. So most of these trials were with erlotinib and chemotherapy, while the BR.19 trial was with the geftinib, and adjuvant CTONG 1104 trial was also with geftinib. All these trials demonstrated some kind of DFS advantage, but which was not translated in the OS benefit. The key type of recurrence is a key consideration in resected NSCLC, as we know that the local versus distant recurrence has an impact on patient outcome after surgery. Local and regional recurrence is associated with longer post-op survival than distant recurrence. It's a common knowledge. Then distant recurrences are mostly lethal. And preventing CNS recurrence is an area of unmet need because CNS is a common site of distant recurrence among patients with EGFR mutated NSCLC who receive anti-EGFR TKIs. In adjuvant RADIANT study, 37% of the patient recurrence in EGFR mutated NSCLC treated with erlotinib had CNS involvement. Osimertinib has been shown to achieve clinically significant exposure in the brain compared with other EGFR TKIs and has shown greater penetration of blood-brain barrier. This was according to the FLORA study, which was done in the metastatic setting. And in the advanced NSCLC setting, first-line osimertinib demonstrated superior overall survival and a 52% reduction in the risk of CNS progression compared with erlotinib and geftinib. In ADAURA trial, type of disease recurrence is important. While we see in both the arms, the osimertinib arm and the placebo arm, the DFS even took place in only 11% of the patient in the osimertinib arm compared to 46% of the patient in the placebo arm. So as we see that the recurrence were far less in osimertinib arm. If we split the type of recurrence into local regional recurrence versus distant recurrence, we see that 38% patient had distant recurrence in the osimertinib arm, while most of the patient had loco-regional recurrence only. While in the placebo arm, most of the recurrences were distant recurrences, that was 61% compared to only 39% that was local regional recurrence. So even if patients who received osimertinib had some kind of recurrence, most of them were actually loco-regional recurrences, which could lead to increased OS. So the most common first site of recurrence were lung, lymph node, and CNS in the osimertinib group. CNS was a recurrence site in only 6% of the patient, while lung, lymph node, and CNS were 11% in patient in the placebo group had CNS recurrence. So overall, we see the CNS recurrence was particularly lesser when osimertinib was used in adjuvant therapy. So here we have Kaplan-Meier survival curve of CNS DFS event in stage 2 to 3A disease. Overall, 63 patients had CNS DFS events, and 3 out of these patients were on treatment at the time of CNS recurrence with osimertinib versus 71% with the placebo, that is 29, which is a huge difference. If we look at the curve, which are separating nicely, so the median CNS DFS was not reached in either arm, while the hazard ratio was 0.24, the maturity is only 13%. If we look at the safety summary, so in osimertinib arm, 66% of the patient completed 3 years of therapy, while 41% patient completed in the placebo arm. That is because of the progression. Median total duration of exposure in osimertinib arm was almost 36 months, which is the duration of the planned therapy. In placebo arm, it was only 25.1 months. If we look at the adverse event profile was favorable, with only 23% patient having any kind of grade 3 or 4 adverse event. Only one patient had adverse event which led to death, and any 13% of the patient had to discontinue their treatment because of the adverse event, while 12% of the patient had dose reduction. If we look at the all causality adverse events, so the diarrhea was the most common, seen in 47% of the patient, while grade 3-4 was actually only 3%. Paronychia, dry skin, and pruritus. The skin-related side effects were there. Coughing, stomatitis, and upper respiratory tract infection were there. And in placebo arm, if we see, so safety data was almost similar. So post-operative chemotherapy use and outcome from ADORA. So a further analysis came out in which patients were studied according to whether the adjuvant chemotherapy was used or not. So overall, as previously mentioned, 60% of the patient had received adjuvant chemotherapy in ADORA trial for a median duration of 4 cycles consistent across treatment arms. The majority of the patients received platinum-based chemotherapy, most with stage 2 to 3A disease and fewer with stage 1B disease, because at that time, benefit in stage 1B was not very clear. So many medical oncologists did not give chemotherapy in stage 1B. Adjuvant chemotherapy use was more frequent in patients who had age less than 70 years of age and patient enrolled in Asia and was not influenced by WHO performance status. So if we see that 80% of the patient in stage 3A received adjuvant chemotherapy, while only 26% of the patient received adjuvant chemotherapy in stage 1B. If we look at the DFS curves in patient with and without adjuvant chemotherapy, here we see then patient who received adjuvant chemotherapy, the curves were almost the similar, while benefit of osimertinib was maintained in both the groups. The median DFS was not reached in the osimertinib group, while 22.1 months in the placebo group. In patient who did not receive any adjuvant chemotherapy, osimertinib group median DFS was not reached, and in placebo group it was 33 months. Hazard ratio was 0.3. The explanation for better median DFS in patient without adjuvant chemotherapy was because probably these patients already had lower stage, that was 1B only. If we look at the subgroup analysis of DFS in patient with and without adjuvant chemotherapy by disease stage, if we see, then the benefit was there across the stages. In all 3 stages we see, if we subdivide, so osimertinib benefit was there in all the stages, in stage 2, stage 3, and stage 1B. If we look particularly in stage 1B, with or without adjuvant chemotherapy, the benefit of osimertinib was there, with the hazard ratio were not reached. If we look at stage 2, the similar story, the benefit of osimertinib was there. And in stage 3A also, the median DFS was reached in both the arms. That was 39 months in the osimertinib arm versus 13 months in placebo arm. In patient who did not receive any adjuvant chemotherapy, it was 38 months versus 11 months. Patient reported outcomes from ADORA. So in Adorat, health-related quality of life was measured by doing a health survey called as SF36, which has two components. One is physical component summary, PCS, and one is mental component summary, MCS. And across these two summary scores, there are 8 health domains which are assessed. So under physical component summary, we have 4: the physical functioning, role physical, bodily pain, and general health. In mental component summary, we have vitality, social functioning, role, emotional, and mental health. According to the health-related quality of data was collected at time of surgery plus minus chemotherapy, at the time of randomization, at week 12, week 24, and then every 24 weeks. It was done until disease recurrence, treatment completion, or treatment discontinuation, whatever comes first. If we look at the compliance with SF36 health survey over time, so compliance rate with SF36 health survey was high in both the osimertinib and the placebo arm, that is more than 85%, so which validates the finding of this survey. So if we look at time to deterioration of physical and mental component summary in both the placebo arm as well as the osimertinib arm, though they were overlap, so which shows that with osimertinib the quality of life was not deteriorated. During the disease-free period, majority of the patient did not experience a clinically meaningful deterioration in PCS or MCS, and for those patients who had deterioration, there was no difference in TTD of PCS or MCS between osimertinib and placebo. To summarize, in this updated DFS analysis of osimertinib versus placebo, patients have been followed for a further 2 years and all had the opportunity to complete 3 years of planned study treatment. Overall, there was 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo with DFS hazard ratio of 0.23 in stage 2 to 3A population. Median DFS was 66 months in the osimertinib arm versus only 22 months in placebo arm. There was also a 73% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo. An improvement in DFS was seen regardless of whether patient received prior adjuvant chemotherapy or not, and DFS benefit across disease stages was consistent following restaging based on 8th edition. Osimertinib demonstrated a clinically meaningful improvement in CNS DFS, and safety profile was consistent with the established safety profile of osimertinib, and it showed new safety concern. With an extended treatment duration, median total duration of exposure to osimertinib was 35.8 months. So these updated data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutated stage 1B to 3A NSCLC after complete tumor resection with or without adjuvant chemotherapy. Thank you. Over to organizers. Over to organizers.
Hello. Yes, sir. So thank you very much, everyone, for joining for today's webinar. And it has been an excellent day for the discussions and talks.
Absolutely.
We have, okay.
So I think we can now conclude the session.
Yes, sir. So for your concluding remarks, over to you, sir.
Okay, so thank you everyone for joining with us tonight to discuss the various advances made in the area of NSCLC, specifically speaking, EGFR mutated NSCLC with a focus on osimertinib. I'm sure this was a delightful talk and everybody got to learn a lot many things. Happy New Year, everyone. So now we'll be closing the session. Good night.
Happy New